Karen's Grandview Men's Program is a highly specialized signature program designed to meet the needs of patients who share similar professional or social spheres, taking careful consideration of work and personal obligations. And today we're going to meet some of the expert staff who work with our Grandview Men's patients. But first, we want to take you inside the unit virtually to get a firsthand look at our facilities and the philosophy behind this innovative program.
Includes Grandview Men, Grandview Women, and also the Legal Professionals Program. I've been with Karen since August 2012 in the clinical capacity, also in an alumni capacity and a development capacity before taking this role. The Grandview Men's Program is here to treat an individual that has had mature life experiences, either in their career, in their family, or just in their own individual journey in life. It is here to provide a program with more amenities and more freedom and more clinical touch points than some other programs. We're set up to bring somebody in to treatment that's never had treatment before. We are also set up to bring somebody into treatment that's had treatment experience before or recovery history before. We have a staff of psychology, spiritual, clinical, psychiatry, and medical. And our clinical staff, we do all of our own groups and lectures and programming here within this building. That provides a safe experience for patients and their families where they feel their anonymity is protected. We also offer first-class amenities. We're a very comfortable treatment stay and experience. All of our rooms are private. They are wired with internet and cable television with private bathrooms. We have found in treating this population that it is very important to allow them to have access to their professional needs while in treatment. They have access to their cell phones, they have access to the computer. We have a business center here for their needs. Within the first 5 days of a patient's admission, they are seen and assessed by a licensed clinical psychologist and their licensed counselor. From those assessments, we determine diagnoses and other specialty tracks of programming that may be beneficial for that individual. Programming like anxiety, CBT, CPT, trauma, and depressive tracks that we have available here at Karen in-house within the Grandview Men's Treatment Building. We also look very closely at personality stylings and an individual's relationship with their work identity and with their money. We have found personality stylings and some of these other, let's call them process addictions, can really interfere with the quality of life in a family system and an individual's approach to the recovery process. Our spiritual staff, our psychological staff, our psychiatry staff are industry experts. We've assembled all those here at Karen to exist under one roof and to be part of your multidisciplinary treatment team. Families are assigned a licensed family therapist here within our continuum, and they are provided touch points and family sessions several times during a patient's stay here. No one's going to force feed anything to you. And we do believe that everybody's path to recovery is just a little bit different. And we will allow you to have that experience.
My name's Dr. Adam Scholey, and I'm the Medical Director and Head of Psychiatry at Karen Treatment Centers. I'm board certified in both psychiatry and addiction medicine. I've been with Karen since June of 2015. In my capacity as Medical Director and Head of Psychiatry, I'm responsible for the medical oversight and psychiatric oversight of all patients on Karen's campus. Specific to Grandview, I'm part of the multidisciplinary collaborative team that cares for the patient's substance use, medical, and psychiatric co-occurring needs. When I get involved with the patient, I stay directly involved with that patient throughout the residential substance use treatment episode. It's important to me that we uncover any co-occurring illnesses that may present an obstacle in the way of sustained recovery. One of the gifts of Karen Treatment Centers is our NEAG Medical Center, at the heart of which is a fully staffed, medically monitored detox unit, ensuring that anyone who enters treatment at Karen has a safe and comfortable detox experience so that they can move forward with the business at hand of addressing their substance use medical, and co-occurring psychiatric needs. One of the most remarkable things about Karen's medical treatment team is leadership's investment in hand selecting experts to treat each patient's substance use, medical, and co-occurring psychiatric need. We're represented by a broad range of subspecialists, including anesthesiology, emergency medicine, internal medicine, general surgery, psychiatry, and integrative medicine. Not only is the NEAG Center staffed with full-time on-site nurses and physicians, but we also have the luxury of being on the same unit, so that it's very easy for us to collaborate with one another at any given moment. With the Grandview program, we go to great lengths to unearth any co-occurring mental health processes, including attachment injury, complex trauma, and post-traumatic stress disorder. It's critically important that we identify co-occurring illnesses because they present an obstacle in the way of sustained recovery. Neurofeedback can be an excellent, safe modality of addressing those issues non-pharmacologically. Karen's biopsychosocial spiritual approach to the treatment of addiction and inarguable industry-leading proven outcomes pave the way for a sustained recovery and meaningful, purposeful life.
Now I'm pleased to introduce some members from our Grandview men's team. I've had the privilege and honor of working with these guys for years. John Post is the executive director of both Grandview men and women's programs, along with the legal professionals program. We're also joined by Dr. Adam Sholey, who's the medical director and head of psychiatry at Caron, Pennsylvania, along with having medical oversight of the Grandview programs. And rounding out the group is Eric Weber, senior clinician for specialty services at Caron and the program director for our legal professionals program. So thanks y'all for being with us today. And we're going to start with John Post, who will reiterate and add to the general overview of the program provided in the video that we just saw.
Am I good?
You're good, John.
All right. Just want to take the opportunity in a minute here just to welcome everybody that's viewing this in the virtual world. Thanks for taking time out of your day today to take a sneak peek into this program with all of us. It means something to us here as treatment providers. I'm very excited to be here and talk about this Grandview program. It's something as a clinician I'm very proud of. It's something that as a Caron employee I'm very proud of. Have had the opportunity to sort of pioneer this program, and I've been involved in some way, shape, or form in the evolution of it. Now we are gender specific, which has been great. It just provides me a great deal of purpose to talk about what we do here, why we do it, and who we do it to. I think just in general, the treatment and separating, whether it's an age group, whether it's a drug of choice, whether it is a gender, we have found it very promising and we've been successful at it, at treating different sectors of the addicted population. Whether it's older adult, whether it's young adult, whether it's teen, or opiate addicted folks, there is a great need for the specialized treatment of people of high net worth, people of affluence, people that have resources, people that have been educated. This disease does not discriminate. And so the Grandview program really exists to welcome those people in, where we chew away at the stigma and we work towards allowing patients and families to have a treatment experience that's unbiased and that really has minimized distractions and it allows for a peer-to-peer group that is very welcoming, as I've said before. Most of our folks, you know, like I said, have had mature life experiences. They've been educated. They have families. They have careers. They come from having been exposed to a lot of worldly things, whether that's travel, whether that's exposure to you know, different careers or whatever else. We welcome that type of person into our Grandview programs, and it's important for them to be with like-minded people in the clinical process. You know, so when they're in groups together, they can look across the room and they can relate to other people that are getting treatment together. One of our biggest, I guess, distinguished selling points to this program is we believe that allowing somebody that does have a professional life to maintain connectivity to that life is very important. We do not take our cell phones from our patients unless there's a clinical reason to do that. We allow time for them to stay connected to the world that they were just uprooted out of, and prior to them coming into this type of setting. And so in doing that, we have this program here where there is a great ability to stay connected to family and to business needs and to anything else that otherwise might be a deep, dark hole in a traditional type of a treatment program. That is all clinically driven, of course. That is not a sort of a blanket rule for everybody, but if there is a reason to not connect somebody to the outside world, we will work with that clinically here in-house. And we'll start to unearth that during the assessment process in the first 5 days. The other thing that I'm very proud of within this treatment program, both men's and women's, is we are sort of a hybrid between primary care and extended care and or relapse focused treatment. We're set up to bring somebody and their family into treatment for the very first time. Most of what we do is education based, it's psychoeducational. And that's primarily what our program designation is. But however, our staff members are all relapse trained, Gorski trained. Our staff have been program directors of the relapse program at one time or another, and or staff members of that program. And so it's great for the patients to experience that, because whether you're a first timer or you're a relapse patient, you can be in group with somebody that's really modeling what not to do and what to do in a recovery journey. It's a really powerful way to express, you know, the roadmap to recovery for somebody that's tried it before, and maybe they had a couple hiccups along the way. And for the person that's here for the first time, it's a really powerful way to model that experience. I guess some else of what I'll talk about is more or less the process as an overview. From start to finish, we have a pretty intensive multidisciplinary assessment approach in the first 5 days. So everything starts at medical. There's a comprehensive medical assessment done. It then goes into a psychological assessment, where we screen for anxiety or any predetermined pre-existing diagnoses, depression, some co-occurring anxiety disorders, maybe even some personality diagnoses that people are coming in with. We have a screening measure for that, and that is done by a licensed clinical psychologist here on the unit. We also do a biopsychosocial assessment, which is done by the clinical staff, and that is a pretty intensive, about a 2-hour, I'd say 150 questions just around getting to know that individual. Where do they come from? What has their upbringing been like? What are their family values? What's their history with drinking? Have they been to treatment before? We do a really deep dive in an effort to get to know a patient and establish rapport, but also in an effort to guide that person's treatment plan and what we're going to do with them for the next 31 days on average. From that assessment, we will also make determinations to our psychiatry team, which Dr. Scholey will talk about. We do a number of personality tests where we test for, different personality styles that might be a barrier to the recovery process. We have found with this population, we have found with this population and with treating people with addiction just in general, there can oftentimes present themes of narcissism, themes of antisocial personality stylings, themes of dependent personality stylings. And we have measures by which we screen for that, and we provide feedback to that individual and their family members. Sometimes people in these positions of power, their family members have struggled to have a voice, and they've struggled to feel like they've been part of the family. There are also elements of control. We screen for all of that, and we look for that on how they might come out in somebody's personality so that we can start to tease through some of that in the treatment process. We do use a series of groups, which I'll talk about later, to kind of dive into that. But I think I've said everything I wanted to say for now as an overview. All right.
Thanks, John. Next, we'll hear from Dr. Scholey, who will speak a little further about our medical acuity and psychiatric capabilities. Dr. Scholey, I'll turn it over to you.
Thanks, Kelly. Thanks, John. And I'd like to echo John's sentiment. It's a privilege to spend time with you today. Thank you for taking the time out of your busy day to get to know a little bit more about what we do here at Cairn. Certainly a privilege and honor for me to represent Cairn and specifically the Grandview Men's Program. John touched on a lot of key points, as did the intro, but what I'd like to focus on is the importance of identifying any co-occurring mental health processes that go along with the substance use disorder. Addiction is really a great mimicker. So when a family sends a family member here, or an employer sends an employee here for treatment, oftentimes we get a lot of background information about behaviors and a lot of opinions about what to attribute those behaviors to. It's not uncommon for people to enter treatment with an alcohol use disorder that's very obvious, and other people will be wondering whether or not they have a major depressive disorder or some kind of mood disorder like bipolar affective disorder. So it's really critically important that we tease that out here at Cairn. And the reason it's so critically important is because if we don't treat each of those potential disorders, then the patient won't recover from either of them, and they're not going to have a good outcome, nor will they have what we consider to be a meaningful, purposeful life. So we do spend a lot of time with patients on an individual basis. The gift of time allows us to observe across the multidisciplinary team that John spoke of, different snippets in time also, and specific intentional encounters with patients. So as the addiction psychiatrist, not only overseeing the medical and psychiatric needs of our patients here at Cairn, but oftentimes I'm directly involved, particularly with the patients on the Grandview unit. So John mentioned the assessments that take place within the first 24 hours to several days, starting with medical and then going into the biopsychosocial and psychological evaluations. If there is something that's identified by either the admitting physician or the examining psychologist, who happens to be a psychologist dedicated to the unit, it's not uncommon for me to be consulted, particularly if it's a case or a situation that might require medication management. That's not always the case. I'm not always just called in for medication management. Sometimes my psychotherapeutic expertise is called upon. If that does happen, I'll do a comprehensive psychiatric evaluation, and I commit to seeing the patient through the entire treatment episode. The frequency varies depending upon the clinical indication and really what the individual patient requires, or at least their perception of what's required. So we do see a broad range of co-occurring mental health disorders. Sometimes it's simply the alcohol or the cannabis or the cocaine that's mimicking what might look like a bipolar affective disorder or an anxiety disorder. But fairly often it is the case that there's a co-occurring mental health process that is addressed across the entire treatment episode by everybody on the team. It's very scary for people to come into treatment. One of the things that is striking about Cairn as soon as you pull up is what a beautiful campus it is. And the state-of-the-art medical facility that we're fortunate enough to have is a very welcoming environment. From the second a patient walks in the door, they're greeted by really friendly staff who understands what it's like to come into treatment. Many of the people who work on campus, in fact, have been through treatment themselves or are in long-term recovery. We have a large full-time nursing department that will immediately begin to care for the patient's needs, whether that be just sitting with them and talking them through what the distress that they're going through, or fulfilling some of the orders that the physician has prescribed for comfort medication. And of course, we try to get patients out of the medically monitored, what most people call detox unit, as quickly as possible, so that they can get onto the unit with the peers that John mentioned, so that they can benefit from interacting with people that are like-minded, have similar experiences beyond just the substance use or the anxiety or whatever condition they have. Because that's where a lot of the treatment takes place. Addiction is a very shaming disease. It's an isolative process that most people enter as they get further along into their disease process, and it's critically important that once they're safe to get to the unit, that they interact with peers and some of that shame starts to subside. In the introduction, it was mentioned that we have a number of specialists that practice on our medical team. My colleagues represent, as I mentioned in the video, a very broad spectrum of subspecialties. And I think why that's most important is there's not a whole lot that we're going to miss. And it also allows us to take patients into treatment who are fairly medically compromised and that are quite frankly turned down by other institutions that don't have as sophisticated medical staff or nursing staff. So there are very few conditions that we would say probably Cairn's not the right place for you. Typically, if that does happen, it's usually that Cairn's not the right place at this time. Either they'll require hospitalization or a more intense stabilization than we're capable of offering at Cairn. But don't be afraid to refer patients, or don't be afraid to pick up the phone if you have a co-occurring mental health disorder, bipolar, generalized anxiety, obsessive compulsive disorder, social phobia, PTSD. If you have someone that you're working with that has psychotic symptoms that are definitely attributable to intoxication from substances, that's something that we would be able to take a close look at and determine whether or not a higher level of care was needed prior to coming into treatment. But we commonly treat a very wide spectrum of illness here at Cairn, and I attribute that to the investment that the leadership has made in hiring the right staff. I think that that's about it. I want to make sure I leave plenty for Eric to cover, because he has a lot of expertise to share as well.
Thanks, Dr. Schiele. First, we're actually going to go back to John real quick. John, can you give us a deeper look at the treatment modalities that we utilize, and also how Grandview incorporates the family into treatment?
Yeah, so I'll first want to talk about some of the group interventions that we do use that are less manualized and sort of branded. But you know, we do group therapy every day, 5 days a week. It's for an hour and a half. It's actually 6 days a week. We do group on Saturday, and at any given time, we could be doing any number of things in that group process. It's all facilitated by a therapist here in the Grandview building. We do things relative to the 12 steps. And when I say 12 steps, I'm really just kind of like focusing in on step 1 and somebody's relationship or the group's relationship with substances. We do a lot of talk therapy around that. And we do some didactic pieces around somebody's relationship with the substance, you know, whatever that may be, prior to them coming in here. We do some trauma informed therapy groups. We do a great trauma egg that is a smaller, intimate group setting. It's in groups of 3 or 4 max, all facilitated by in separate rooms with different therapists. That is a 2-day event. We usually do that once a month. It's a great way for somebody to tell their life story and for us to identify some maladaptive themes that they may have gotten, you know, somewhere along their journey, whether that be by their family of origin or, you know, an event that may have happened at the bus stop in the 4th grade. It's a great storytelling exercise that we use as a way to model some maladaptive behaviors. We do a family abstract portrait, which is an art-driven sort of an experience, and we just have a lot of great clinicians here. We have a lot of fun in the group dynamic and the group process, and it's something that we put a lot of time and effort into. The modalities that we do use, I think the one that I'm the biggest fan of is our CBT, our cognitive behavioral track. And we're taking people that have had themes of or pre-existing diagnoses or current diagnoses of depression and anxiety. And we are teaching them first off, what that diagnosis means and how it presents to them in their life. So that group is run by a licensed psychologist. And we're taking some belief systems that a person has. Again, they may have got it at the bus stop. They may have got it in their professional life. They may have got it through being a parent, some of the anxieties that go along with that. But we're taking a certain belief system and we're trying to turn it into a lie, essentially. And part of the CBT process is the group work around that and extrapolating how that belief system can become a major problem in a person's life. That modality provides a lot of comfort to our patients. For the first time, I think they'll see, and any one of them will probably tell you this, they find comfort in finding other patients that have had the same narrative. And they find comfort in a room where that narrative is accepted, and you know, they allow us to kind of do some undoing type work with that narrative. We do some meditation and yoga. We do trauma-based yoga. We do a meditation every morning that is led by a staff member here. That is a 30-minute, it's usually guided. We do get into some bowl work and some different types of, what would you call it? Just different types of sound and breathing techniques. We're fortunate enough to have a staff member here that's very passionate about meditation, and so she does lend herself to our group to take them through a guided meditation every day of the week, 7:30 to 8 a.m. We're very proud of that piece. We also have a very manualized CPT program that is done over a 12-session time frame, where we are starting to desensitize perhaps a traumatic event that a person may have went through in their life that has you know, stuck with them and has caused them some PTSD and some inabilities to maintain connections in relationships, or even, you know, relationships with themselves. It's a very manualized thing that, again, we're fortunate enough to have CPT providers on this unit that focus on just that, and that's cognitive processing therapy. Of course, we use MI. That's basically one of the very the efficacy of MI with this population is probably just about the only way you're gonna find that you're taking a high functioning person to a place of vulnerability is through MI, motivational interviewing. Generally, these folks in this population don't like to be told anything. So they have to get there on their own. And how do you get them there on their own? You do that through motivational interviewing. So we do supervision as staff, and we do talk about ways that technique can be more beneficial and more helpful per case. I want to give a shout out to our family therapist, Melinda Castro. She's not in the room today because she's busy doing some sessions. If you haven't heard that name yet, write it down. She has been a godsend for this program. She is our full-time licensed family therapist. She puts in a lot of time with these families, and she basically takes the addiction as out of the equation. I mean, that's my job, that's Eric's job, that's the therapist's job to focus on the addiction. And what she will do, which I think a lot of families have found a lot of salvation in, we talk about the dynamics. You know, how does somebody communicate? What are their shortcomings? You know, what ticks them off? What makes them happy? And we really get under the hood and get into some interpersonal stylings of marriages, of business partners, in children and parent relationships. We're very gifted to have Melinda here, again, to take the addiction out of the equation and look at interpersonal stylings of a relationship. That sort of piece it starts on day 5 after we've presented a case to the team. Melinda will then get in and meet with the patient individually. She'll meet with the family member individually. She'll present a series of assignments to those individuals, and then she will come together and do some family sessions, collective family sessions with those identified parties. We do that on WebEx now that we're living in the COVID world. And we hope to soon, and I don't know what I mean by soon, but we hope to be in person sometime in the not too distant future. But that's been a very big part, and a very, you know, it's been a clinical, it's really one of the focal points of our clinical process here is our family work. We're very proud of that. We put a lot of time into it because we know that it needs to be done.
Thank you, John. Now we're going to hear from the lovely man in the bow tie, Eric, regarding specifics around addiction interaction disorders and the treatment available on Karen's Grandview.
Thanks, Kelly. Appreciate it. Thank everybody for being here. So I'm here to talk a little bit about addiction interaction disorder, and one of the reasons I'm here talking about it is I'm a certified sex addiction therapist, certified multiple addiction therapist. I'm certified to treat gambling as well. Side note, I play in a rock band, so sex, drugs, and rock and roll is kind of what we do here, right? So jokes aside, it's very rare that somebody comes in with just a substance use disorder. That how many times, as Dr. Sholey mentioned, we're dealing with co-occurring. As John's talking about the family program, there's layers of issues with the families that a lot of times are related to other behaviors that become problematic. And whether that is infidelities, whether that's workaholism, whether that's gambling, we find these things are there. They're not always talked about. The principal reason somebody's coming to treatment might be because of the alcohol, cocaine, opiates, prescription pills, whatever. But in reality, there's other layers of stuff that's in there that we would be remiss if we didn't take a look at. And so one of the things we're able to do, particularly in the Grandview unit, these things get hidden because of the high functioning, typical high functioning of our patient. As one of my colleagues like to say, for our patients, they might be getting an A in business and a D in life. But because they got an A in business and their professional life it might be untarnished, it might not be harmed yet. Then we really do need to take a look at all those things underneath the professional life to be able to say, look, for a full recovery experience, for really true health, we need to take a look at all this other stuff. Just putting down the drink, just putting down the pills or the drugs. There's a lot of other things. And so we will assess for gambling addiction. We will assess for sex addiction. We will assess for workaholism, internet addiction. And for a lot of our folks, it might look like workaholism, but they're simply in a profession where it requires a lot of hours. People who own their own business, who are required to be available more hours than just 9 to 5 weekends off. And we need to pay attention to that reality. And as John mentioned, our unit is specifically designed so people can stay in touch with the professional world because it's a necessity. If we have a patient who owns a business and in his or her livelihood really is the foundation for all the employees' livelihood, it's important that we help support that. And so on this unit, in conjunction with helping them maintain some sort of a balance with professional life, it's also assessing and looking at what needs to change in the recovery life. And whether that's doing some career counseling about hours, travel, functions. For many of my patients, we talk about what it's like to be in an airport. How do you travel? An airport's the perfect place for an alcoholic. 2 a.m., 2 p.m., you can drink, nobody cares. So the person in early recovery, how do they make it through getting on an airplane, which is a bar traveling at 35,000 feet at 350 miles an hour, and you can't just get off. And so equipping our patients with the coping skills for their life, when they will be at fundraisers with champagne, will they be at brunches with people drinking, when they're at business functions, we're at a steakhouse with $500 bottles of wine, and they're faced with, gee, I really don't want to drink, but look at the situation I'm in. So when we take a look at not only addiction interaction disorder, but just generally the lifestyle that they will return to, finding the coping skills necessary, developing coping skills necessary, finding out what the triggers really are and being able to address them, and managing the system as a whole, whether it's working with the family members, whether it's working with business partners. I'm the director for the legal professionals program, so I work with the lawyers, judges, and law students coming in, how to manage the professional life in a professional world that is soaked in alcohol, to be perfectly blunt. It's ubiquitous in that atmosphere. And so it's important for us to be able to identify what those issues are and be able to give good, solid, concrete coping mechanisms moving forward. So as I mentioned, there's a number of evaluations and tests we can give. We have clinical opportunities to be able to address this. Once a month, I do a day-long workshop just on professional life. We talk about work, we talk about work-life balance, we talk about return to work in some very real terms. And as a group, they're able to give each other feedback and give each other experience, strength, and hope if they've done this before, express anxiety if they've not. And so we give specific clinical opportunities for that, as well as I run a relapse workshop once a month. As a former director of the relapse unit for 5 years, having had some experience with the relapse population, whether somebody's coming in for the first time and it's more focused on relapse prevention, or somebody's been to treatment multiple times and it's a chance to take a look at how can I make this my last treatment experience and a successful one. And we'll spend a day looking at relapse process, typically why do people relapse, what are some fundamental triggers and issues that come up, and what are some strategies moving forward, and try and tailor that for each individual depending on where they fall in their own personal relapse cycle and experience. So it's a little bit of what I do. Kelly, I'll turn it back to you.
Thanks so much, Eric. Now I want to spend just a couple minutes talking about the admissions case management side of patients and families coming into this program. We're very blessed to have an incredible admissions team at Caron under phenomenal leadership of Megan Schlott. And the way this looks, if you're calling about Grandview Men's, Women's, any of our signature programs, from that initial phone call, whether it's from the referent, the patient, or the family, a multidisciplinary approach is utilized to determine if we are in fact the best program for that individual. At Caron, our mission is recovery for life. So we want to help people achieve that, whether it's through Caron or another program. So we really, we take that very serious, and we always want to do right by our referents and our patients and our families. So what that looks like when you make that call, you speak with one of our admission specialists and we get a lot of information. And at that point, Dr. Sholey, some of the other physicians, depending on what's going on with the patient from a medical perspective, get involved. John himself is heavily involved in all cases coming in, as well as Eric, if we're looking at a legal professional or someone who addiction interaction disorder is part of their story coming into treatment, to ensure that we can in fact meet their needs, but also to answer questions that they have. As we all know, this is a huge step it's a major investment, not just financially, but emotionally, physically. Most of our patients are not local, but from all across the country. So we want to make sure we're able to answer their questions and give them a thorough understanding of what treatment's going to look like through all the different lenses. So just know that you don't have to wait until you get to Karen to meet John or Eric or Dr. Sholey or some of our psychologists or other physicians. That happens from that first phone call until the person is either with us or at whatever the appropriate level of care for them is. Next, we want to move into the Q&A section of this. I just want to remind everyone, if you have a question, you haven't submitted it yet, please use the Q&A feature at the bottom of your screen. I can tell you we do have a lot of questions that have come in, so that's great. More than likely, we won't have time to get through all of them, but please know if we don't answer your question, someone from our team will follow up with you following this to make sure that your questions have been answered. So for the first question, I'm pulling up my list here. Dr. Sholey, I'll give this one to you. You spoke on this briefly, but just to clarify for a question that's come in, what level of psychiatric acuity can Grandview support, as well as what type of psychological testing is offered at Grandview? And I know John briefly mentioned some of the psych testing, but Dr. Sholey, if you can just kind of summarize from an acuity standpoint and a psych testing standpoint, what that looks like for our Grandview patients.
Thanks, Kelly. It's a really good question. And we are not an acute psychiatric hospital or facility. We actually do not have the license to hold someone here against their will, nor would it be appropriate to have somebody on our campus, given how vast it is, if they would present a danger to themselves or others. So I think somebody who is acutely suicidal or acutely psychotic, absent intoxication, we might be able to look at and determine whether or not that was a thought process that they had or a mental state that they were experiencing because of the intoxication. And once they were no longer intoxicated, they felt very differently. We typically would not take somebody who's acutely psychotic or acutely suicidal. Other cases that we look very carefully at center on disordered eating behaviors. And typically with those cases, what we're looking for, number one, are they medically compromised as a result of their disordered eating? Number two, do they have insight into their behaviors? While we are capable of managing people medically here, there are certain things that we're not capable of doing, including IV fluid hydration on campus, or tube feeds or parenteral nutrition. So those are just some of the things that come to mind. Oftentimes we'll have patients that have a bipolar affective disorder and they just stop taking their meds. And it's clear that when they stop taking their medication and they drink, they behave in a certain way. And it's also been established historically that when they stop drinking and go back on medication, they're fine. So Kelly mentioned that we have a team that looks very carefully at each case that's presented to see whether or not they're appropriate at that given time for this level of care. Was there a second half of that question that I missed, Kelly?
It was just about the psych testing.
Oh, so thank you. We have a phenomenal psychological team here, doctoral level psychologists who are very, very skilled in diagnosis and treatment. And part of their diagnostic skill set for several of the psychologists involves psychometric testing. At baseline, there's a certain standard that we follow for any patient that comes in. And typically that will involve some of the personality testing that John mentioned, and some cognitive screeners. If there's identified by the screen that a deeper look is required to determine how much executive function, for example, is impaired, then we certainly have the capacity to do comprehensive neuropsychiatric testing on this campus.
Thank you. John, I'm going to give you the next question. Is how do you manage someone who is not interested in anything 12-step based and is not interested in attending meetings while in treatment?
Yeah, another great question, Kelly. You know, we don't force feed any one vehicle to recovery. I think at one-time treatment as a whole in the industry and the evolution of treatment, you'll find that the 12 steps were, you know, largely the only way, you know, that people would get sober. And so one of the ways I like to describe Grandview is we're more free-spirited in that regard. We like to talk about themes related to the 12 steps. Maybe not force feed the book or the traditions and, you know, all these concepts that bring with them a whole lot of preconceived notions and stereotypes and prejudices. So we're very self-serving in that regard. Our patients run a recovery-based meeting every night. That does not have to be 12 steps. It can be Dharma. It can be, you know, Don Ruiz material. It can be Anthony DeMello. We try to invite a lot of these free-spirited concepts into our continuum so that each patient can find something that they can relate to.
That's helpful. Thank you. And that actually segues into another question that we got as it relates to 12-step programming. They asked, after treatment at a program like Grandview, how does a client acclimate to recovery support groups when there's a more diverse crowd?
I think, Kelly, I'll take that one. I think a lot of it depends on, to John's point, what did the patient relate to? And some folks are looking for a similar demographic, and given certain geographic areas, we can use our alumni resources to help guide them to supports that they can relate to. And I know for me personally, that's a very direct and open conversation I have with my patients. You know, who are you relating to? What was most meaningful for you? And so that we can help set up a meaningful aftercare plan that if somebody says, look, I really like to hear the nitty gritty. I really like to hear the down and out stories. I really, you know, because that really keeps it real for me, we can direct them in one direction. If somebody else says, look, I need somebody who understands my real world problems, who understands the issues that somebody of means may have and not scoff because I'm a person of means, somebody who can really relate to me on that level, and we can direct them to alumni and support services that will be meaningful to them and really be able to, for them to feel like they can be honest and vulnerable, because that's really what that's about, is not feeling judged for who one person is, but rather being accepted.
Thank you, Eric. I'm actually going to give you this next question. They want to know, are there any specialized programs offered within Grandview? The examples they gave are things for like trauma, co-occurring disorders, chronic pain, gambling. I know you mentioned the addiction interaction disorder treatment, but can you speak a little more to the specialized groups that are offered for patients in treatment?
Certainly. The short answer is yes. The longer answer is, for each of those things listed, there is at least a group or a clinician to meet with to support the needs. So if somebody has trauma, it's identified, we as a team will take a look and see, do we put them in a general trauma group? Is it focused PTSD specific, and maybe they're appropriate for cognitive processing therapy, and we will direct them to that. If somebody, I'm the gambling guy on campus, so anybody who pops positive for a gambling issue, or even the question of does this person have a gambling issue, I will sit down for an individual session to assess and discuss, and also then how to integrate into the treatment process. If necessary, I'll follow up on a weekly basis with individual sessions. If I have multiple gamblers and it makes sense, I will run a gambling group. So it really depends on what the needs are. But I think as John and Dr. Sholey have intoned, whatever issues are coming up, particularly in Grandview, because we are a smaller, higher touch point program, we can direct them to services that'll support whatever their needs need.
Thank you. And Dr. Sholey, I'm going to throw this question at you. They would like to know, how do we determine if a patient would benefit from neurofeedback treatment?
Another good question. I'm glad that we're touching on neurofeedback because it is potentially an excellent modality for treating a number of disorders or even symptoms, quite frankly, such as anxiety or depression, inattention, what some people would call attention deficit hyperactivity disorder. So that there is a unique to Grandview program. Every patient does meet with the neurofeedback team that's headed by a neuroscientist, PhD, and they get a brain map. And then after the mapping, the patient sits down with the neurofeedback team and discusses what the map looks like. Without going into detail, it'll be identified whether or not they might benefit from neurofeedback as an intervention. And oftentimes patients will find relief in either answer. Like, you would benefit from neurofeedback, or, hey, your map looks pretty clean. I'm not sure that this is something that would be indicated at all. And if neurofeedback isn't indicated, there are some other modalities that might be offered by the neurofeedback team, such as alpha-STEM.
Thank you. John, I'm going to give you this next question. They said, my client does not identify as an alcoholic, but can acknowledge that alcohol prevents him from being as successful as he'd like in relationships and with work. Would this client be a good fit for Grandview?
Yeah, again, another great question. I'm sure a lot of family members are or have thought of this in the past in their, in their search for to get a loved one some help. But that essentially that's what we specialize in. We allow an environment where we invite somebody into our therapeutic community and our therapeutic process, and we specialize in self-diagnosis. What we say to these folks, as I've said before, at the end of the day is relatively meaningless. We like to bring them into the conversation, and we like to allow them to have their own experience. So whether that's done in group or whether that's done in an individual setting, we look for ways to allow our patients to identify how to increase their meaning in life. And if that means drinking less or not drinking at all, if that means, going to meetings or not doing X, Y, or Z, we talk about that. We create a conversation with the family members involved, typically. We like to create that conversation, and we like the conversation to be all inclusive, and we like to go from there.
Thank you. This next question, we have a couple minutes left. John, Eric, whoever wants to answer it. The question is, how does Karen integrate business coaching into treatment?
I can take that one because I spend a fair amount of sessions doing that. There's a couple of ways we can look at business coaching. If it's a simple, it's a fairly simple, straightforward, just processing, and somebody needs a think partner of either how to reintegrate into the work situation, how recovery might impact work life. That's pretty straightforward. That's actually fairly common. We do have a staff member in our Florida office, a gentleman named Jonathan Salzberg, who does have a business background and can do a deeper dive if somebody is really interested in doing some more executive coaching, business planning. I've had patients who work with Jonathan and actually setting up a business plan to start a new business after recovery has been established. So we can go pretty far into that. Somebody meets with Jonathan, we do that teletherapy, and we just set up some times. We can also set up for executive coaching post-discharge. We have some consultants we're working with. So if somebody says, look, I really appreciate this kind of approach, and especially as it's intersecting with my recovery life, we have staff that can continue to follow with somebody for some period of time after treatment to give them that support.
Thanks, Eric. And we have time for one more question. John, I'm going to give this one to you and just talk quickly, but I do think it's an important question. How is spirituality integrated into the Grandview program?
Yeah, so we have we're very fortunate, again, to have a doctoral level staff member here in our building that carries a very unique passion for spirituality. I mean, that's her whole wheelhouse, that's her domain. And through our assessment process, we involve this staff member, Dr. Meredith Hardy. She's been with Karen for decades. And you know, we allow people to come up with their own tapestry for a belief system in that area. We don't force feed. We don't look for. We don't, try to, presuppose an idea onto somebody else. We allow and encourage a patient through the realm of talk therapy and identify ways in which spirituality can be an added, an added layer of success in their locus for change in their recovery programs.
Thanks so much, John. I want to be mindful of time. I know many of you submitted questions that we did not get to today. Again, we will follow up with you afterward to make sure your questions get answered. I want to say thank you to John, Dr. Scioli, and Eric, and all of our attendees for joining us today. And before we conclude, I want to share an opportunity with you coming up from Karen. We are hosting our 6th annual Addiction Research Symposium on November 4th and 5th. Presenters are from the NIH, the National Council for Mental Wellbeing, Johns Hopkins Medicine, and our own Karen medical leadership team. And it'll be showcasing the latest evidence-based practices, treatment models, cutting-edge research. And this event really bridges the gap between practice and research to improve the care of those suffering from substance use disorders. So registration is now open for that. We hope you can join us. And finally, please reach out to your local regional resource director regarding admissions to any of our programs, questions about services or resources or events in your area. And thank you again for joining us today. We hope to see you soon.
Thanks, Kelly.